Yeah, very good evening, all, my dear doctors. So, I am Dr. Sepuri Krishna Mohan, Senior Endocrinologist at my own center, Sepuri Diabetes and Endocrine Center, Kurnool. And today we are going to talk about the sulfonylurea glyclazide actually. So, first of all, let me tell you what is there to talk about the old molecule, the glyclazide. See, nowadays we are talking much about the DPP4 inhibitors and the SGLT2 inhibitors and the GLP1 receptor agonists and the novel analog insulins and all. See, as a speaker, I am only talking about all these things. So on daily basis, and you can see it on my YouTube channel. So you just type my name, Dr. Sepuri Krishna Mohan, endocrinologist. You can see my YouTube channel. All the topics, even day before yesterday also, I talked about the combination of the SGLT2 inhibitor plus the DPP4 inhibitor, that is FDC of dapagliflozin 10 milligram and sitagliptin 100 milligram in the management of type 2 diabetes mellitus. And you might be surprised why I am talking about this glyclazide, an old molecule, and that belongs to the class of sulfonylurea. So let me begin with the the greatest landmark trial ever done in the field of medicine, not only diabetology, not only endocrinology, entire medicine. There is no such big study, no such greater study, no such longer study, which is none other than the UKPDS, that is United Kingdom Prospective Diabetes Study, which was started in way back 1977. Probably I was in 5th class or 6th class. So after 10 years, they started evaluating 87, and after 97 again, 20 years after the study has started, they have evaluated, and again 2007 after 30 years, and even 40 years after 2017, and still it is going on. It is called UKPDS ongoing. So why it is called UKPDS means because it was done from different centers from United Kingdom actually. So that is the largest and the longest and the greatest study in the field of medicine. There also, the drugs used were, that time we had not too many drugs. The anti-diabetic drugs were, first was metformin, second was glibenclamide, and third was insulin. And coming to the next topic, the hypertension, they also saw the two parameters, like they were lowering the glycemic control and lowering the blood pressure control. Okay, so the molecules used were the one beta blocker, the atenolol, and the AC inhibitor, captopril, which were available at that particular time only. So there starts the significance of this particular sulfonylureas, and it has its own value. As and today, all over the world, there are many prescribers for this particular sulfonylureas because they have got its own value. See, every the scientific session, the every speaker program, I am invited by the ADA or the EAST or the IDF, International Diabetes Federation. It gives me a little bit pinch that they say something different about sulfonylureas. They write the classification of the anti diabetic drugs or the oral hypoglycemic drugs, OADs, are they write, and when it comes to SU, they write the tagline, about to vanish, about to disappear. But I want to tell you the fact that the most sophisticated country in the world being the United States of America, for every single patient, it is giving the loose tablets of glibenclamide or glipizide or glimepiride or glyclazide. The loose tablets, see, we are getting these tablets in the strip form. At least they give some dabbas, all small plastic tins, and on the one hand they say we don't use this particular sulfonylureas. On the second hand, the other hand, they give only this particular molecule along with metformin, of course. And a computerized label will be there, a sticker on that, the patient name, age, and the dose. If it is glibenclamide, it is 5 milligram. How many tablets to be taken, like 1 BID or 2 BID? So something like it is written. It is the practice. See, they say something, they do the other thing. So that is the importance and significance of this sulfonylurea, and that too we can classify these sulfonylureas into like three categories, like the older ones and the newer ones. The older ones, which are no more available, are tolbutamide and chlorpropamide, and the newer ones, out of that, the old molecules are the glibenclamide and the glipizide, and the newer molecules of sulfonylureas are the glyclazide and the glimepiride. Glyclazide probably in the modified release or the extended release, that's what. So a country like India, a developing country, we we always I always teach that, okay, don't touch the pancreas, please, because if you touch the pancreas, you squeeze out all the insulin that is secreted from the functioning beta cells. No longer it's going to be available for the body. The insulin gets exhausted, and the pancreatic beta cell mass, that becomes bankrupt, and that is a stage called pancreatic bankruptcy, and the patient has to be on insulin forever. So saying that also, in spite of that, keeping the high HbA1cs in view, and the low cost of this the sulfonylureas, so we start a combination with definitely the first drug to start with is the metformin. Added to that, the either the glyclazide. See, somebody is making lot of noise actually. Can you please mute yourself, please? Yeah, thank you. Somebody started the motorcycle. I am getting that buzzing sound actually. Please, all of you, I request you to mute yourself, please. Please do not make noise, okay? So, metformin along with a sulfonylurea, if not controlled, okay, we'll go for the third drug definitely. So, if it is not contraindicated, I would love to suggest and cast my vote to pioglitazone low dose. And then if it is not controlled and the A1C is above 9, around or above 9, insulin must be initiated. And of the late, the newer drugs have come, the so-called the DPP4 inhibitors and the SGLT2 inhibitors and the GLP1 receptor agonists. So now the cases where we straight away don't use the sulfonylureas, in my clinical practice from the last 32 years, I tell you, a new patient comes to you like newly detected diabetes with an A1C of 7.5 or 8, 8.5, not touching 9. If it touches 9, there is no other go other than insulin. This is not my recommendation. I am giving you the reference of the American Diabetes Association standards of medical care in diabetes according to 2023, the latest one. And if the patient has got a fasting plasma glucose of 140 or 150 and a postprandial 2-hour postprandial glucose around 200 and 220, I all the time would not go for a sulfonylurea. I would like the triple drug combination, that is the combination of extended release or the sustained release of metformin 1000 milligram and definitely a dapagliflozin 10 milligram or empagliflozin 25 milligram for the affordable segment, and inevitably either the vildagliptin 100 milligram SR OD or the sitagliptin the 100 milligram, because these are off patented actually. So this is the best molecule for that particular patient. The molecules which act only on the, the peripheral mechanisms, not touching the pancreas, not squeezing out a single unit of insulin. So the patient is not responding to this. We are supposed to either go for insulin or this particular sulfonylurea must be added to that. So with that background, without the particular the importance of sulfonylurea, which cannot be ignored in our scenario, especially where there is no comprehensive insurance system and the patient has to spend everything from his own pocket for the laboratory testing and the consultation fees of the doctor and the special investigations, and for the medicines the patient has to spend from his or her own pocket. We don't have the comprehensive healthcare system as we have in the US like NIS, or in the UK like NHS, the National Health Service. That's what. We don't have that system. So that is the reason a country which is loaded with 141 crores of population, it's not easy to give all the medicines free of cost. So with this definite background, and I'm going to start the today's topic, the place of glyclazide in evolving the type 2 diabetes mellitus. So you may think that, oh, what is there to talk about glyclazide? See, it's not something like it, it, it's not something like putting old wine in the new bottle. I am not doing that. I am going to give you the evidence-based medicine today about glyclazide. Every parameter, every sentence I commit is only evidence-based medicine, only evidence-based medicine, nothing other than evidence-based medicine. And this is my disclaimer. And you can see the busy slide actually, the trends in add-on medications following the metformin monotherapy for the type 2 diabetes mellitus. And our objective is to examine the national trends in second or third line anti-hyperglycemic medication. We are not talking about the first line. It is undoubtedly the metformin, unless otherwise metformin is contraindicated or it is not being tolerated by that particular patient. These are the only two contraindications where we cannot prescribe metformin. That is intolerance to metformin, either the patient has got consistent diarrhea and all, the GI upset and all, everything, the dyspepsia, bloating sensation, where we cannot use it. So this the first, second thing is the contraindications for metformin. The main contraindication being a renally compromised patient where the EGFR goes, the estimated glomerular filtration rate goes around or below 30 ml per minute bar 1.73 meter square of body surface area. So first drug is all the time metformin, and now the question is, what is the second drug mostly used, and what is the third line of drug mostly used. So to examine the national trends, in the second and third line antihypertensive, anti-hyperglycemic medications following metformin monotherapy, the comparing trends from 2015, we have taken two parameters. One is 2015 and one is 2019. It's a retrospective cohort analysis, and the number of patients were 31,750 in 2015 and more than 43,336 in 2019. So when you come to this thing, the second and third line therapy overall actually. So as you take this, the second line, we come start with the second bar actually. The second line drug, as on 2015, it was 39.1% of the patients were put on this particular sulfonylurea as a second line drug of choice. And when it comes to the 2019, the scenario is totally changed. It is only 29% because the latest drugs have come. I have told you the DPP4 inhibitors and the SGLT2 inhibitors and the GLP1 receptors, actually GLP1 receptor agonists. So that is the reason 39 has become 29. So the usage as second line drug, this particular sulfonylurea, has come down by 10% from 39% to 29% from 2015 to 2019. So likewise, the next one is the other oral drugs, that is 4.6 actually, and the combination drugs 5.9, and the DPP4 inhibitors 12.7%, and the SGLT2 inhibitors 14.7%, and the GLP1 receptor agonist it is 16.8, and insulin 16.3 actually. So the same thing, like you can compare this particular the molecules which I have said, they respectively from 2015 to a shift in 2019. Likewise, the third bar now we are talking about, the as third line drug of choice, this particular sulfonylureas actually, either the glibenclamide or the glipizide or the glyclazide or the glimepiride, as third line of drug of choice, 2015 it says 17%. It has come down very drastically, like. So the third line in 2019 has become 11.5%. So there is a slash by 6% almost. So when you compare all these things, the usage of insulin is increased actually from the first line, the second line it was around 15.8 or 16.3 in 2015 and 2019 respectively, has drastically been increased to 29.5 in 2015 as third line, and the 29.7 more or less similar, the 2015 2019 as second line, and 2015 and 2019 the third line, it is drastically improved and increased. Somewhere around 30% is using insulin, and the you can compare all these things. And one more thing is the usage of the SGLT2 inhibitors and the GLP1 receptor and the DPP4s have been increased simultaneously. So the inference from this particular slide is the sulfonylureas remain the leading second line of choice. And this is the bar diagram showing the real world usage of sulfonylureas in Asian patients with type 2 diabetes mellitus using the JADE register. JADE is nothing but Joint Asia Diabetes Evaluation Register. This is maintained by the Hong Kong Medical School, where Professor Juliana Chan is the chief investigator for all this jade. And fortunately, I was happened to be the one of the principal investigators in jade diamond trial. Under her guidance, Professor Juliana Chan. She is a lady, very dynamic lady from Hong Kong Medical School. She is the head of the Department of Medicine and Endocrinology and Metabolism. So the real world usage, according to the JADE register, what it shows is the cross-sectional analysis data from adults with type 2 diabetes mellitus from 11 Asian countries are the reasons with structured assessment enrolled in the prospective JADE register, that is Joint Asia Diabetes Evaluation Register, and the number was 62,512. You can see, like the green, light green, what you are seeing is the sulfonylurias, and the light purple, what you are seeing is non-sulfonylurias. The light sky blue, I think. Okay, color may vary. Okay, so if you take all, see, overall the 11 countries, the China, Hong Kong, India, Indonesia, Korea, Malaysia, Philippines, Singapore, Taiwan, Vietnam, and the Thailand, actually, you can see all the countries, more than 50% to around 70% of the patients, this particular sulfonylurea is being used, and less than a quarter, around some less than 30% approximately, are put on non-sulfonylurea drugs. So this is the inference we can take is like the 59.4% treated patients received SU based therapy with variations amongst the countries and variations. See, I have told you roughly around the 70%, but like China is little bit less in using the sulfonylureas. So taking an average of all the 11 countries, all the 62,512 patients, the average is around somewhere around 60% of the patients are using the sulfonylureas, and the 40% are put on non-sulfonylurea drugs. So the same thing, the real world usage of sulfonylureas in the Asian patients with type 2 diabetes using the Joint Asia Diabetes Evaluation, that is JADE register, and you can again see on the left hand side the bar diagram, the drugs the patients are using. The first the color is it's pink, I think. Pink is metformin, and after that metformin plus sulfonylurea, and after that metformin plus DPP4 plus sulfonylurea, and sulfonylurea, metformin, and sulfonylurea thiazolidinedione. So this is a very busy slide. So, and coming to the right hand side, the first one is the glyclazide, and that's what I mean to say. What is it like? The four types of the sulfonylureas, actual four drugs that belong to the sulfonylurea class of drugs. So first one is the glyclazide, the second one is the glimepiride, and third one is the glibenclamide, and the fourth one is glipizide, and others are depicted in the different colors. So the sulfonylurea regimens, the sulfonylurea plus metformin is around 79.5%. Almost 80% are on sulfonylureas as a second drug of choice, in combination with the metformin being the first line of drug. So second thing is the sulfonylureas plus DPP4 inhibitors to a tune of 22.1%. Among the sulfonyl users, the inference I am telling you, among the sulfonylurea users, glyclazide was most prescribed, that is to a tune of 46.7%, followed by glimepiride, that is 40%, and glibenclamide 8.1%. And I still find patients using the glipizide, which is much more safer than glibenclamide. And one more point I have to add here is, if the patient is on glibenclamide, you need to stop it once the patient reaches the age of 60 years for the fear of severe hypoglycemias. So, coming to the sulfonylureas, place of sulfonylureas in the diabetes therapy. So, you can see the placement. If it is used as initial therapy, that is the monotherapy or combination therapy with metformin, the two categories. Usually, we don't use it as a monotherapy unless otherwise the patient is very much emaciated, where insulin is to be prescribed, and the patient bluntly says no insulin. Even let me die, but I don't take insulin. Such a stubborn case, we have to, like, where the body mass index is around 15 or 16, whatever it may be, where that is one of the contraindications for metformin. We cannot use it in such an underweight patient. So, our combination with metformin, the indication being the first I said, the monotherapy, the contraindication to in the metformin, and intolerance to metformin. I told you in the beginning itself. See, if the patient is put on sulfonylurea as a monotherapy, that is the only one condition that where the patient has got the contraindication to metformin or the intolerance to metformin. The combination therapy with metformin, the high blood glucose levels at presentation. And second line of therapy, that is add-on therapy, that is adequate glycemic control with metformin. And subsequent add-on therapy, add on to the combinations. That is, when we add on, the indication being inadequate glycemic control with the existing oral therapy, where you cannot reach the glycemic triad properly. That is, the fasting plasma glucose and the 2-hour post glucose and the A1C. These three are called the glycemic triad actually. And the special consideration, the biological factors, I said, age more than 60 years, or the renal impairment, or the neonatal diabetes, and MODY 3, that is maturity onset of diabetes in the young, and the psychosocial factors like the glucophenotype, that is during Ramadan fasting, or where the fasting plasma is very much high, that is fasting hyperglycemia is the uh, case that is to be addressed, or the postprandial hyperglycemia. So, with that, we move on to the next slide. The glyclazide, the metabolic and the cardiovascular effects. Okay. See, I'm talking about not the plain glyclazide. I'm talking about the modified release or the extended release or the sustained release of this particular the glyclazide. So glyclazide plain per se, you need to use it BID, but this MR can be used. The plain glyclazide MR can be used once a day. So it is available in the form of 30 milligrams the modified release, 60 milligrams, 90 milligrams, and 120 milligrams. So this acts on the pancreas, this acts on the kidney, this acts on the heart, this acts on the vessels. So what is it going to do on pancreas? Okay, let us see what glyclazide modified release is going to do on pancreas. Okay, that is going to reduce the apoptosis, and that reduces the endoplasmic reticulum stress, which lead to a better glycemic control. And on the kidney, the reduced oxidative stress that leads to the reduced albuminuria. And on the heart, it improves the IPC, what is called the ischemic preconditioning. This is a better molecule compared to the glabenclamide, which goes in the opposite direction, where that worsens this particular the ischemic preconditioning. So the best molecule is the glyclazide or the glimepiride. The increasing the ischemic preconditioning is associated with the better cardiovascular outcomes, the less incidence of 3-point MACE or the heart failure per se. And on the vessels, so how glyclazide modified release acts on the vessels, okay, by increasing the endothelial progenitors and by improving the endothelial mediated vasodilation and by reducing the LDL oxidation, which put together lead to a better cardiovascular outcomes. Sridhar, put it on hold. So, sorry for the technical glitch. Now it is clear. Okay. Now, after finishing that, the benefits of glyclazide modified release on the various organs we have seen, and now we are going to talk about the efficacy of glyclazide actually. So the real world usage of sulfonylureas in Asian patients with type 2 diabetes using the JADE register again. So this is a busy slide. The inference is the glyclazide usage was associated with a higher likelihood of achievement of the reductions in the HbA1c less than 7% and more than the use of other sulfonylureas, and the rate of self reported hypoglycemias was 19% lower in the glyclazide group than the non-glyclazide sulfonylureas. So this is to be given like to understand that the particular glyclazide molecule is associated with less hypoglycemias when compared with the other the sulfonylurea, the glimepiride. And this is a bar diagram showing the glycemic control with the glyclazide XR, extended release. It's a model based meta analysis of 229 studies, and the number being 1,21,914 actually. So, if you see that the bar diagrams, the first one, the red one is the glyclazide MR, which was able to reduce the A1C by 1.04%, the metformin by 1.01%, and the glimepiride 0.97, and the sitagliptin 0.72, and the vildagliptin 0.69, the dapagliflozin 0.73, and the saxagliptin 0.67% respectively. So the inference is the glyclazide effectively reduces HbA1c by 1.04 compared to the other oral anti-diabetic drugs or the other the sulfonylurea is the glimepiride. And the improved control with the progressive uptitration. You can clearly see the three bar diagrams, and that is on the x-axis it is month 0 and after 3 months and after 6 months, and on the y-axis you can see the A1C, HbA1c. So the drug used in the first bar diagram is the 30 mg, after that the 60 mg, after that the 90 milligram and the 120 milligram of the modified release of glyclazide. And simultaneously the same thing, after the 3 months we can see the results, after the end of 6 months we can see. This is from ECDIA study. Actually you can very clearly see that after 3 months there is drastic improvement in the reductions of A1C with all the strengths, the 30 milligram or the 60 milligram or the 90 milligram or 120 milligram, and the significant reductions after 6 months from the zero, that is base level, that is from 8.3 has become 6.7 with 30 milligram of the modified release of glyclazide. From 8.6 of A1C it has become 6.9 respectively, and from 8 it has become 7, and 9.2 has become 7.3. That is, the maximum efficacy is seen with this particular, the 120 milligram, and even the lowest dose 30 milligram also is very efficacious, and 60 milligram, 90 milligram, any strength is going to be very effective in reducing the A1C levels. And the inference is that 1.78% decreased in mean HbA1c across the HbA1c spectrum, and 2.3% reduction in mean HbA1c of the range being 8% to 10%. That is, higher the A1C, the reductions are more. That is the take home message from this ECDIA study. And this is guide study, that is a direct comparison between the glyclazide modified release versus the glimepiride. So you can clearly see on the left hand side, see the A1C at which glyclazide was started was 8.4%, and the glimepiride was at the second the graph that depicts the glimepiride, which was